Nice to meet everybody. I'm so glad to have a chance to talk with you. Today's topic is a new shift in paradigm in borderline personality disorder. Now, these ideas are not necessarily those of Sierra Tucson, and I won't even say that my ideas are correct. But what I would like to do is talk about some things in a way that we can look and see if there's different ideas we can get and that we can also share together. I need to let everybody know I'm not an expert in borderline personality disorder. What it is I've had experiences over the last 37 years as a psychiatrist, and I'm just sharing some ideas that have come to me over time. So that's what we'll be talking about today. I will talk for about 20 minutes and then leave enough time so that we can have answering of some questions. So the first thing and the first way we want to start is, what is a personality disorder anyway? And a personality disorder is really not a mental illness. Personality disorder is a characteristic of way that someone behaves in the world that have involved changes in thoughts, feelings, and behavior that create a difficulty for them throughout their lives and also create difficulty for other people. Now, the problem with our personality disorder diagnoses that we have in DSM-5 and in the previous DSMs was that these diagnoses are categorical. In other words, that we name them, such as borderline personality disorder or paranoid personality disorder or avoidant personality disorder. And the problem with that is that our personalities are much, much more complicated than those diagnostic labels that we give. And so we want to look at personality in a broader sense in terms of various dimensions of our experiences, such as our affect regulation, such as our introversion or extroversion, such as tendency towards anger, tendency towards excessive amounts of guilt, all broad range of things rather than just looking at things in categories. So the same thing applies to borderline personality disorder. I like to look at the idea that the way we have it defined now is not a good way of looking at things because it is a categorical diagnosis that does not necessarily reflect the reality of what we're dealing with. So I like to talk about a paradigm shift, and that paradigm shift has to do with a whole new way of looking at things in terms of psychopathology and the way we approach psychopathology. Now, for the past 120 years or so, what we've used is a psychopathology model, and that is we're trying to find out what's wrong with a person, what their characteristic symptoms are, how they match with other people with similar symptoms, how we can categorize people in groups so that we can learn to study things, we can do research, we can communicate with one another about what these problems are. And it's been a very, very useful way of looking at things. But a new way of looking at things, a paradigm shift, is to say, okay, let's look away from emphasis on psychopathology, but let's look instead about nervous system regulation and a regulation model that is more accurate in terms of what we know about brain development, attachment, growth of the emotions over time, so that we're not looking at the pathology per se, but we're looking at things from strengths and resources based. So we're looking at more in terms of a positive view rather than a negative view. Now, when we think about this, it comes down to two things, and I'm oversimplifying here a little bit, but all our difficulties, except for serious mental illness, of which there is, but all our other difficulties come down to a combination of difficulty in managing emotional regulation or anxiety and difficulty with interpersonal relationships. And the two are very connected because we know from the polyvagal theory that the more dysregulation we have in our systems, the more disrupted our interpersonal relationships. So one of the things we want to focus on is regulation of the nervous system, because that will automatically involve improving our interpersonal relationships. So let's take a look at what's talked about in terms of borderline personality disorder itself. We're looking at a number of different symptoms that people have, or a number of different problems, such as fear of abandonment, difficulties with emotional regulation, self-harm behavior, impulsive self-destructive behavior, volatility, anger outbursts, self-harm, those sorts of things. Now, if we look at the idea that there's not psychopathology, then we would say in a sense, there's no such thing as borderline personality disorder. What we have is really maladaptive coping mechanisms that are used to cope with a dysregulated, highly dysregulated nervous system, which is often secondary to trauma or genetic factors, or both of those. So I would like to say that to challenge people to look and say, well, maybe there's not such a thing as borderline personality disorder. We're just giving a label or a name to a pattern of behavior that we see. Now, the problem with this pattern of looking at things is that it involves the problem of the other. And this is what I like to talk about, is that anytime we make an other out of somebody, we will automatically disrespect them, mistreat them, create problems for them, disrespect them, and that sort of thing. And that's because our brains developed over thousands and thousands and thousands of years with tribal brains. We grew up in tribes of 150 to 400 people that competed for resources, land, food, etc. Now, in those organizations, the other tribes were considered not people or not people. They were considered the other. And we still do that, and we have tribal brains. We make an other. We do this in terms of sports, which is a good way to look at it. We have different teams, so I'm this team, you're that team, that sort of thing. But when we make an other in psychiatry, it results in some problems. And I'll give some examples of the problem with the other. I am male, you are female. I am straight, you are gay. I am white, you are a person of color. I am well, you are mentally ill. I am staff, you are patient. I am German, you are Jew. I am normal, you are borderline. So every time we make an other out of somebody, we will automatically mistreat them, whether or not we want to, or whether or not we're recognizing that we are. And this is a problem with using the label borderline personality disorder, is that we will cause problems in terms of we will disrespect them. We will not engage in the same way we engage with other people. And the clients or patients will know this. They will recognize that in us because they're very used to recognizing small changes in other people who they might interact with because of the histories of trauma, which are highly existing in these sorts of patients. Now, I want to tell you a story of, although I preach this about not being the other, a story on myself for when I've done the very same thing. So we all have to be highly aware. A few years back, I was working, and they asked me to see a patient who had come in, and this patient had had problems with schizophrenia. Now, normally we don't deal with problems with schizophrenia in Sierra Tucson because we are a high emotionally charged environment, and those individuals don't really tend to do well in that environment. Well, this was not my patient, but she was highly agitated and paranoid, and I said, well, do you see her? So I brought her in my office, and we talked together, and very quickly I noticed that she was extremely agitated, got increasingly loud, angry, paranoid, and I was concerned that something might happen that would be negative. So I did what I was taught to do, and that is I brought her out into a larger area where there were more people around rather than stay in my office. Now, she did calm down as we were around other people, and some of the staffs and some of the safety staff came by. And then we had a chance to talk together. And as we talked, we discussed the idea that maybe some anxiety medication might help her. And our plan was to give her some anxiety medication, have her go to sleep, and then we would talk after she rested a little while. Then I turned and I walked away. And this woman caught me. She said, Dr. Seymour? And I said, what? And she said, aren't we going to have a proper goodbye? And what I had done was I had made her an other. I had made her someone with schizophrenia rather than just another human being, and I had disrespected her. And we all will do that. And that's a real problem in our psychiatric settings because we always can look at it in terms of, well, I'm staff, you're patient. And that's why there's a lot of trauma and difficulty that goes on in psychiatric hospitals and in treatment settings where we are not knowing it, but we're mistreating people. So now, when we think about the problem of the other, then what I'd like to do is to do what I did about 10 years ago was to say, okay, what happens if I say there's no such thing as borderline personality disorder. What happens if I pretended I never heard the idea before? I never read anything about it. I didn't even know that it exists. And if somebody said borderline personality disorder, I would think, I don't even know what you're talking about. What changes that would make? And what I found was it changed my approach to people. It changed the idea that I was looking at the things that were positive about them rather than focusing on the psychopathology. And I noticed that I tended to disrespect them a little bit less. So what I instead came up with that borderline personality disorder was simply maladaptive coping mechanisms. Again, to deal with a highly dysregulated nervous system, which is often secondary to trauma and or genetic factors or both. And that allowed me to look at things a little bit different. And because of the lack of disrespect that could be picked up by the client, we had much better working relationships than we had before. Now, the other thing is that when we look at pathology, I like what Ron Kurtz, who is the founder of the Hakomi method of treatment, which was the precursor to somatic experiencing and central motor psychotherapy. And he said, the first thing I do when seeing a patient is look at something about them to love, to admire, or the heroic. Now, this is what I teach our therapists to do is first things what we have to do is find something about the client or patient to love, to appreciate or admire. Now, if you're looking at something to admire in a client or patient or looking for where they are heroic, that changes your attitude towards them and it changes the way they feel because they know you're looking at something that's positive. So what I say to the therapist is if you don't find something to love and appreciate in your patient, then you probably better have somebody else be seeing that person rather than you. Now, the reason I like the word love rather than just loving kindness or compassion is because to me, loving kindness or compassion implies that I am a little above you and I'm granting something to you that you need that I can give. I like the word love because what love means is I want to treat the other person exactly the same way that I would want to be treated myself. And this makes a big difference in terms of the tone that we use with clients, the way we approach setting boundaries with clients, those sorts of things. So now, not everybody will agree with me. These ideas are my ideas, and they're not necessarily commonly accepted ideas. I've talked with a number of people who do believe in looking at there is no such thing as borderline personality disorder, but that's my own personal thoughts and other people's personal thoughts and don't represent maybe a majority viewpoint. And the thing is, I might be wrong. I might be looking at things in the wrong way. And I do like to hear from other people about what they think. So I wanted this presentation to be one of a more conversational tone and one in which I wanted to have plenty of time for questions because people may strongly disagree with what I have to say, or they may agree with me and maybe not thought of things in that way. So that's what I mean about a paradigm shift in looking at borderline personality disorder. It is part of a paradigm shift in looking at all forms of psychopathology. But I think it's especially helpful for the so-called borderline personality disorder because that's a group that we have set apart. We have talked about them as different than everybody else. We've used it in a pejorative way. It carries a lot of stigma. And the problem with that is sometimes we used to think of it as untreatable. But really, these are problems that people have that are responsive to the same sorts of treatments that we provide for other people, particularly dialectical behavioral therapy, which was developed by Dr. Marshall Linehan, who I see as a genius in this field. Now, when we're looking at dialectical behavioral therapy, we're looking at the merging of opposites, which is what the dialectic means in terms of Greek. We're also looking at the merging of the opposites of acceptance and then change. What we want to do is we want to accept the client fully as they are, and we want them to accept themselves fully as they are before attempting any kind of change. Now, AA knows this. When we think about AA, you don't have to stop drinking to become a member of AA. All you have to do is to want to stop drinking. So if you come into a meeting, you're accepted as you are, you're loved upon, but you're not left there. After being accepted and loved upon, there is a slow expectation of change through the 12 steps. Now, different religions have the same idea of acceptance first and then slow change. So that in Buddhism, there's an idea of acceptance, the radical acceptance of what is, both in you and in the world. But we're not left there and we're expected to change and following the eight-way path of Buddhism. Christianity has the same thing, the idea that we're accepted by God for just who I am at the time, and then slowly over time begin to change. And that gets rid of a lot of shame, because if we try to get people to change before they're really accepting of themselves, then it feels like shame, and because they can't do it. And one of the things about shame is we know that's pervasive, and also one of the strongest emotions that people have to deal with, that is trouble for some of them when we're dealing with post-traumatic stress disorder, developmental disorders, dissociative disorders, and those sorts of things. So now the other thing is, so where did this idea come from in terms of borderline? And it came from the idea that when there was just analysis, there were groups of people that could be analyzed, and there were groups of people who could not be analyzed, and there were groups of people who looked like they could be analyzed, but the analysis didn't actually work and actually became problematic. So the first group was those that have psychotic disorders, and they could not be analyzed. The other group were what were considered the neuroses, and these are the things that we have run-of-the-mill problems with anxiety, depression, those sorts of things that are common, but to non-psychotic degree. And the people with the so-called borderline, they looked like they could be analyzed, but they couldn't, and so they were termed borderline, or in the middle between those that were neurotic and could be analyzed and those who could not be. Now, we've done the same thing now. Our diagnostic categories are so non-specific that now we talk about cluster A personality disorders, which actually are the psychotic-like disorders. We talk about cluster C, which actually are more neurotic disorders. And we talk about cluster B, which includes antisocial personality disorder, histrionic personality disorder, borderline personality disorder, and narcissistic personality disorder. So we've really come full swing around things, and so we're using non-specific ways of dealing with people. So that's all I want to say right now, and I want to open the idea up for questions. So I'm going to open up for questions right now and see what we want to talk more about. So first question is, where have I seen progress if we use mindfulness techniques with the client, but they may not be doing the work outside the session? Do you usually encourage they attend classes or groups to keep practicing emotional regulation, or does the client with high emotional dysregulation benefit more from DBT? One of the things I think of is mindfulness is that we often look at that in terms of meditation. And what I think of mindfulness, however, is anything that allows us to step back and look at ourselves in terms of our sensations, our emotions, our thoughts, our behavior, or behavior in relationship to others. Anything that allows us to step back and look at that is mindfulness. So that meditation is a form of mindfulness. Now, with any kind of psychotherapy, I think it's always useful to give homework assignments. Now, not everybody will follow through with their homework assignments, and we have to make sure that when they don't, that we don't shame them or create shame in them by somehow them thinking they're a failure in some way. Now, dialectical behavioral therapy is interesting because it is initially developed for those with the so-called borderline personality disorder, but those ideas of distress tolerance, mindfulness, emotional regulation, and interpersonal effectiveness are actually beneficial for all of us across the board. So I think DBT is useful for any kind of psychiatric disorder or psychological problem that we experience. Okay, now we have another question, which is, what are the similarities between borderline personality disorder and dissociative identity disorder, and how can they be distinguished? One of the things that we look at is that with dissociative disorders, a lot of the anxiety is managed through dissociation. So what I have found is many people with dissociative identity disorder are very highly functional in life. They have good, stable relationships many times, stable job, work for a number of years, and because they have that part of their personality, part of their self, which is the going on as usual self, which is able to do that despite their dissociation, and actually because of their dissociation. People with the so-called borderline personality disorder often don't function very well in life. They have poor interpersonal relationships, instability in terms of working with others, emotional problems that doesn't allow them to work interpersonally well with other people. So they tend to be not as effective in life. However, there's also people with DID that have these symptoms of the so-called borderline personality disorder. So it's much more complicated than that. You can have symptoms and problems of both. So that's kind of how I look at it. Okay, let's see. We have another question. Have you ever considered brain SPEC scans to find the co-occurring mental health disorders that many times show with those diagnosed with borderline personality disorder? I think that's a great question because there often are co-occurring disorders such as depression, alcoholism, severe anxiety disorders, and those also need to be treated both by psychotherapy and often by medications. So there's no specific medication treatment for borderline personality disorder, but there are for the co-occurring conditions, so the medications are often helpful. Now, here at Sierra Tucson, 10 years ago when I first came, we did SPEC scans on nearly all our clients and patients to see if we could find what are some of the brain abnormalities that are associated with different conditions. And what we found was is that they were not really that useful. They were most useful in looking at patients who had some degree of traumatic brain injury, and you could really see the signs of the traumatic brain injury in the SPEC scans. But they weren't really helpful to us in distinguishing other psychiatric problems from one another, so we quit using them. Although it seems like a great idea to use brain scans, I would like for us to have something that's more specific than just going on symptoms. We're not really able to do that in a way that makes sense that we can use. Okay, why is it that borderline personality patients are able to stop using drugs easier than addicts? I'm not sure exactly how to answer that because many of the people with borderline personality disorder or the so-called borderline personality disorder often have problems with addictions. So, and I don't know the literature on that, so I don't know if it's easier for them to stop using drugs or alcohol than others. I think that's a very good question, but I'm ignorant on that right now and can't really answer that question. I just don't know. I'm sorry I don't have a better answer. What are my thoughts about the disproportionate diagnosis of women with borderline personality disorder? That's a great question because if we look at it, most people that we diagnose as having borderline personality disorder are women, not men. And I think that's for several reasons. One of the reasons is that in general, men tend to have more problems with anger outbursts and anger rather than emotional difficulties with anxiety when we're in a fight or flight position. Now, that is an overgeneralization. The other thing I think is that we denigrate women in this society. Women are not on an equal status with men, despite all the things we've done, despite feminism, despite all the changes we've tried to make. Women are still discriminated more than men are, and I think that's a part of why there's more diagnoses in women than in men. Let's see. Another question is, some borderline personality disorders behave malevolently, manipulating others, and sometimes intending harm. This goes beyond the feelings of helplessness, insecurity, and need for secure attachment. And that is clear. There are some people who do behave malevolently towards other people, and that I would lean more to the idea that they might have something more like antisocial personality disorder. And if you look at the diagnosis of personality disorders that we have now, the most one that is most reliable and consistent and actually replicable is the diagnosis of antisocial personality disorder. So it may be closer to a more genuine entity than other personality disorders. Now, in terms of manipulation, if we look at that, we see that in a lot of clients, particularly in those with borderline personality disorder. But I look at manipulation in a different way. The positive way of looking at manipulation is the person with the manipulation often has generally never had a chance to have their emotional needs met by asking directly. So they learned how to ask indirectly through manipulating or trying to get other people to change their behaviors. That's because when they ask directly, they don't get their needs met. So rather than look at manipulation, I look at that more in a positive light. Um, let's see. Have there been instances where people develop symptoms of borderline personality disorder when in a relationship with an addict or alcoholic? Um, that's a very good question. When we think of personality disorder characteristics of what we think of those as beginning in adolescence or early adulthood with long-term behavior patterns that are fixed. But I have seen a number of people who have been very, very steady, and then in relationship with an alcoholic spouse or someone in their life, develop patterns that may be similar to borderline personality disorder because of the trauma that's experienced. And being in those situations, we may respond by more animal defenses such as flight or fight or dissociation and collapse, and often develop some of the same signs and symptoms that we might see in someone who would be called as having borderline personality disorder. Let's see. Do symptoms of borderline personality disorder dissipate as the client grows older? I think we've seen this across the board in what we've considered as so-called personality disorders. Some of the more severe symptoms, particularly those of self-harm and manipulation and harm of other people, tend to diminish as time goes on. But this is across the board in psychiatry, so it's not specific to anything like borderline personality disorder. But in general, most of us, as our brains develop and we get a little bit older, we do have less problems in terms of externalizing problems. Now, we do have problems with depression and anxiety, but in some of those things like self-harm or manipulation of others, those tend to diminish over time. Now, let's see, we have time for another question. Um, uh, let's see, what again are the signs of borderline personality disorder? Helplessness, need for secure attachment, etc. Well, there's first of all high fear of abandonment. There is emotional dysregulation. There is problems with interpersonal effectiveness or communication. There's difficulty in self-harm and a lot of self-destructive, impulsive behaviors, so addictions, bulimia, other self-destructive behaviors are very common. And so those are some of the major symptoms of borderline personality disorder, or what we call borderline personality. Now, I think we need to draw to a close. I am available to answer any questions through email, which will be sent to you in a letter. And I also will be happy to have a back and forth conversation with you through email, or even if you want to email me your telephone number, I'd be glad to talk on the phone with you, because I think this is a very important topic and one in which we all have different ideas about, different thoughts about, and is problematic in working with clients who have emotional difficulties. So that's all I'll say today. Thank you very much for being here,